everyone. On behalf of the PHRN, I'd like to welcome you to today's Linkage Learning webinar. My name's Felicity Flack and I'm the Senior Manager Strategy and Services at the PHRN. I'm speaking to you today from the University of Western Australia, whose campus is situated on Noongar land. Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs and knowledge. First of all, some housekeeping. If you've got any questions for today's speaker, please type them in the Q&A box at any time during the presentation, and we'll try and answer as many questions as possible at the end of the presentation. This presentation is being recorded and we will make it available on the PHRN YouTube channel as soon as possible after the webinar. So let's get started. I'm delighted to introduce Professor Rachel Neale from the QIMR Berghofer Medical Research Institute, who's going to talk to us today about the D-Health study, which is a fabulous example of how linked data can supplement a clinical trial. So I'll leave it there and hand over to you, Rachel.
Thank you very much, Felicity. It's a pleasure to be with you all today. I will just share my screen so that we can get started. Okay, so as Felicity said, today I'm going to talk to you about the D-Health trial, Australia's largest ever medication trial, calling vitamin D a medication here, and how we harness the power of data linkage in order to capture the critical outcomes for this trial. So before I get started, I think we need a little bit of background. And for those of you who aren't familiar with vitamin D, I thought we would briefly start with that. So as you will almost all be aware, we make vitamin D when we expose our skin to sunlight, and in particular the UVB wavelengths in sunlight. So your little tip for today is that you cannot make vitamin D when you go on your early morning or your late afternoon walk, because there is no UVB around at those times. You do need exposure a bit later in the day. When we expose our skin, the vitamin D that's produced is not active. It has to undergo a couple of activation steps. One of those occurs in the liver to produce a molecule called 25-hydroxyvitamin D. And that's what your doctor measures when they order a vitamin D test. It is, however, still not active and has to go under another activation step in the kidney to produce 1,25-hydroxy-D, which then has really important actions on our intestine to help with calcium absorption. Our bones also involved with maintaining adequate calcium. And we now know that it also plays an important role in managing our immune system and a bunch of other things as well. So we launched the D-Health trial at a time when there were a lot of observational studies that had linked vitamin D to actually over 100 different health outcomes. And it was causing a lot of media around this issue. It was actually causing people to get more sun exposure. It was causing conversations in the Australian policy setting about whether or not we should be doing routine fortification of more foods with vitamin D in order to supplement the entire population. And the other thing that it was causing was this massive increase in vitamin D testing. From 2000 to about the end of 2014, there was this over 100-fold increase in vitamin D testing, despite the fact that actually these tests are not particularly accurate. And there's a lot of controversy over the concentration of 25-hydroxy-D that we should have in our bloodstream anyway. You can see that big drop there, and that's because the federal government went, this is too much. There is an epidemic of testing and it is too much. So they actually introduced rules around who could access MBS-funded testing, which caused a big drop, but it's been on its way back up again, and we've got more recent data to show that this increase has continued. So there is still a lot of belief in the importance of vitamin D and a lot of testing going on. To try and answer some of the questions around vitamin D and its importance for health outcomes, we established the D-Health trial. And it's particularly important to understand that We weren't aiming to determine whether or not treating vitamin D deficiency would be beneficial. We already know that frank vitamin D deficiency is not great for our bones. It was more to ask about what would happen if we did do population-wide supplementation of older Australian adults in order to shift the average 25-hydroxy D concentration upwards in the entire population, and at the same time, remove any deficiency that was existing in the population. So the D-Health trial design was a randomised, double-blind, placebo-controlled trial in Australian adults aged over 60. We did not recruit anyone who was already taking more than 500 international units of vitamin D per day, or anyone who had contraindications for vitamin D supplementation. We gave them 60,000 international units per month or a placebo for 5 years. And one of the real advantages of this monthly dosing, we did it because actually it causes a really similar shift in 25-hydroxy D concentration as daily or weekly dosing. There were pharmacokinetic studies that showed us that, but it also meant that we could really get good compliance with the intervention. We sent people either, we got everyone to take their tablet on the first day of each month, and the day before we would send them a reminder via text, email, and if they didn't have either of those, we used a landline, an automated landline reminder. So we recruited between January 2014 and May 2015, and the intervention was complete in March 2020. The outcomes of the trial, the primary outcome was all-cause mortality. Secondary outcomes, cancer incidence and colorectal cancer incidence. And I'll just say that we're literally just analysing the cancer data now because of delays in cancer registration. So we had to wait a bit to get the cancer data. And then a bunch of other outcomes, pretty much things that I dreamt up at night, including, in fact, sleep, which is not listed there. But things like major cardiovascular events, various different markers of infection, hypothyroidism, false fractures, diabetes, cataract, keratinocyte cancer, hypertension, depression, pain, cognition, erectile dysfunction, telomere length and microbiome. So a bunch of different outcomes that occur commonly enough in this age group, and that we could capture either through self-report or through linked data. So outcome measurement, and this is where the discussion about linkage becomes really relevant. So mortality, many of you will be used to linking to the National Death Index through nationally through the AAHW. We actually needed to obtain hospital data from all the states. So we had to do state-based linkage anyway. So we actually did separate state-based linkage to the Register of Births, Deaths and Marriages. And we got cause of death data as well, but there was a bit of delay in coding of that. So we also got the text cause of death. Cancer incidence has come from the state cancer registers. Major cardiovascular events, we used hospital admitted patient data, MBS data, and the death registers. Hypothyroidism, we captured by looking at treatments, like drug treatment, through linkage with the PBS, but we did use hospital and cancer registry data to capture anyone who had had thyroid cancer and had started medication following a thyroid cancer rather than as a result of autoimmune hypothyroidism. We looked at hospitalisation for infection using hospital admission patient data, antibiotic use for any cause using PBS, cold and flu using self-report in surveys and in a sub-study, diaries completed in winter. We used hospital admitted patient data and MBS to capture fractures and cataract. We used PBS data to capture diabetes, hypertension, and hypercholesterolemia, I can say it now, using medication data as the indicator for people having been diagnosed with those things. MBS captured keratinocyte cancer, also called non-melanoma skin cancers. For depression, we got self-report, but we also used new treatments with antidepressants. Pain and erectile dysfunction were self-report in surveys, and cognition, we used a telephone interview for cognitive status. And then not listed here, but we also collected stool samples to look at the microbiome. and blood samples to look at telomere length and also to capture 25-hydroxy-D concentration in our groups over time. Our analysis followed the intention to treat principle for the most part, and we mostly use flexible parametric survival models to calculate hazard ratios and 95% confidence intervals. Many of you will be more familiar with Cox regression models, but the advantage of these flexible models is that we can actually look at how the hazard ratio changes over time. One thing that I did want to flag is our approach to the analysis. We take a very gold standard approach where we produce a detailed statistical analysis plan, which is informed by the data, but we give our analysts a data set that doesn't have people's study group assignment in it. So they can explore the distribution of the outcome that we might be looking at, for example, and the missingness and factors associated with missingness, but we do not give them the study group assignment. In order to produce the code that outputs the submission-ready tables and figures, they randomly assign people into 2 study groups. So they write all the code on this dummy data. We send examples of what the tables and figures will look like to our co-authors for review and approval as part of the statistical analysis plan. We make any changes using the dummy data, and only when that has been locked down do we then give the analyst the study group assignment. They apply that code to the real data so that we can see what happens. So that prevents any data dredging, going, oh, I don't like that p-value, or I do like that p-value. I'll only present those data. We present everything, even just in supplementary, of everything we said we would do. And then importantly, if we see something really interesting and we go, oh, we need to explore that further, we do, but we declare it as an exploratory analysis. We try and take this same approach for some of our observational data analysis as well, so that we really avoid that biased analysis and reporting. So I would really encourage many of you to consider taking this approach to your data analysis. Just a snapshot of some of the papers we've published. We've actually published 18 papers from the D-Health trial now, so my team has been working extremely hard. All right, so some results. We sent invitations that we recruited primarily via the electoral roll, so that was our sampling frame. We sent invitations to 421,207 people. We also did allow additional volunteers to take part. So we had 1,896 people who volunteered and we had 40,000 people who expressed interest in participating. But by the time we removed people who were ineligible or who decided not to consent, we randomized 21,315 people. After randomization, we did have a few people who withdrew and had their data destroyed. But one of the real advantages of using data linkage is that we had very little missing data because we used this passive follow-up to get complete data capture. So it's only when we were looking at some of our self-reported outcomes that we had missing data. And also because PBS and NBS requires a completely separate consent form, there were some people who didn't consent to linkage with Services Australia, but because they had to give consent before we randomised them, it was completely unbiased in terms of no systematic differences between the 2 study groups. So some selected baseline characteristics, you can see that we've got the vitamin D group in blue and the placebo group in red. You can see the groups were extremely well balanced. And we had slightly more men in the study than women, and it's because more women were taking vitamin D, so we're ineligible. As is consistent with the Australian population, the majority of people were overweight or obese. We did have fewer current smokers than the general population. We only had about 5%. General population is a bit over 10% at the time. We actually had fewer people reporting that they were in fair or poor health. So that's one of the differences we had with the overall population. And then the other thing is that we did not, just sort of flag that we didn't measure everyone's 25-hydroxy-D concentration at baseline. It would have cost a couple of $1 million and we couldn't justify it because the study wasn't powered for subgroup analyses. But to enable exploratory analyses, we did predict people's vitamin D at baseline, and we predicted that about 25% of people would be vitamin D deficient at baseline. So most participants did complete the trial. At the end of the study, there were 80% of the vitamin D group and 78% in the placebo group still taking tablets. And the overall compliance, which was defined as having taken at least 80% of the study tablets. So we had just over 80% of people classified as fully compliant. There were a few people who actually bailed out of the study really early and took less than 30% of their tablets, but very few people who took that intermediate number. So you can see that the retention and adherence in this study were exceptional for a 5-year study in this age group. The serum 25-hydroxy D concentration, we took samples from a random sample of participants each year, and you can see that in the placebo group, it stayed very stable at about 77 nanomoles per litre. So less than 50 is considered deficient. Some people consider less than 75 deficient. So our people were in the sufficient range according to the recommendations at the time the study was done. And we saw a big difference in the vitamin D group, so it was 115 nanomoles per litre, and that stayed consistent over the course of the trial. Response to request to give us blood sample was over 80%, so this is pretty representative of the overall population. I just thought I would flag that the amount of work it takes to achieve these sorts of outcomes is huge. Project managers for this study were Catherine Baxter and Brian Eduardo Romero, and our study physician, Don McLeod, also did an enormous amount of work. We dispensed 125,000 tablet packs from QIMR Berghofer and sent 100,000 annual surveys. So the difference between annual surveys and tablet packs is because we had to dispense them at baseline, and then we didn't start sending annual surveys until 1 year in. But also people would have things like the dog ate their tablets, which did actually happen. So we had to do things like take SIN replacement packs. We made nearly 95,000 phone calls where we actually made contact and left another 35,000 messages and had another 10,000 unanswered calls. We responded to nearly 19,000 emails individually, as well as all our mass emailings. We updated 10,000 contact details. And Don had to report on 5,685 adverse events, although the team coded them. In our HREC system at QIMR, there are 397 attachments. So you can see that a study like this, achieving the sort of retention, etc., was an enormous amount of work, and we're very proud of the quality of the data. So here's the high-level overview of the outcomes. Outcomes with some evidence for benefit were infection, major cardiovascular events, fractures, depression. I actually don't have a slide on depression, so I'll just flag this one now. A reduced depression score in people taking antidepressants at baseline, and reduced risk of new antidepressants in people predicted to have low vitamin D at baseline, and hypothyroidism. We didn't find an effect overall, but we found some evidence of benefit in women where hypothyroidism is much more common. We found no effect on all-cause mortality, cognition, keratinocyte cancer, pain, cataract, erectile dysfunction, the microbiome, or telomere length. So just showing you a couple of these outcomes in a little bit more detail. For all-cause mortality, our primary outcome, there were 1,100 deaths. These were equally distributed between the study groups, and the hazard ratio was 1.04. And you can see that these survival curve is sitting very close to one another right throughout the trial. For cardiovascular disease, there were 1,336 events. This is a pooled outcome of myocardial infarction, stroke, death from cardiovascular disease, or coronary revascularization. So that's a stent or a bypass graft. So 1,336 events. The overall hazard ratio was not significant. It was 0.91 with a confidence interval of 0.81 to 1.01. But the hazard ratio for myocardial infarction was more marked, was 0.81 with confidence interval of 0.67 to 0.98. And we saw a similar effect for coronary revascularization. There was no effect on stroke. And you can see that for the overall, we see this separation of the curves for the vitamin D and placebo groups, with placebo in blue, a higher cumulative incidence. And one of the things that was really interesting to note is that we saw a stronger effect in people who were taking statins or other cardiovascular medications at baseline, probably not due to any sort of interaction with these medications, but because these are indicators of people who were at higher risk of experiencing a cardiovascular event at baseline. For fracture, it's highly controversial about whether or not treating people who are not deficient has any benefit for fracture. We didn't see any overall benefit with a hazard ratio of 0.94 and a relatively wide confidence interval. But what we did see was a benefit starting to emerge from about 3 years in, and the hazard ratio at 5 years was 0.83 with a confidence interval that did not cross 1. So there's arguably some evidence of benefit for fracture. Infectious disease is very interesting. We measured this in a number of different ways. So we looked at acute respiratory infections, so basically colds and flu. And we asked people about this in surveys and in diaries. And we saw no reduction in the incidence of experiencing an acute respiratory infection. But we did see fewer days with symptoms, than fewer days with a worse symptom score, and less need for medication for symptom relief. We also saw less need for antibiotic use, although there wasn't that much antibiotic use, so with a wide confidence interval. But our interpretation of this, and it's consistent with what we see for other things, is that vitamin D doesn't reduce the likelihood of you getting an infection, acute respiratory tract infection, but it does reduce the how bad those infections will be and how long they will last. We also looked at antibiotic use from the PBS data, and we looked at prescription episodes. So a prescription episode was classified as any episode where there was one or more prescriptions that occurred within a 30-day interval. And we didn't see any benefit overall, but we did see fewer prescription episodes in people predicted to be vitamin D deficient at baseline. And interestingly, we saw fewer repeat prescription episodes. So these are episodes with 2 or more prescriptions occurring within them rather than only one. And again, a more marked effect in people vitamin D at baseline. So this overall benefit here is consistent with a more with a reduction in nastier infections, just like our acute respiratory tract infection. And then we used hospital data to look at hospitalization for infection. We looked overall, and in pre-specified analysis, this is really important. It was based on our looking at the data before we saw any randomization group. We decided we would also look at extended hospitalizations lasting more than 3 days or lasting more than 6 days. And those cut points were based on the distribution of the number of days that we saw in the data before we began the analysis. So we saw a slight reduction in hospitalizations lasting more than 3 days, but a quite marked reduction in the number of extended hospitalizations lasting more than 6 days, again consistent with this reduction in nastier infections. So what are the implications for these findings? I've given you some evidence that vitamin D at a general population level in a population that was largely not vitamin D deficient, that there's some evidence of benefit, but it's probably not sufficiently convincing, or the effect sizes are too small to justify population-wide supplementation through food fortification. However, we do think there's sufficient evidence to develop policy about either sun exposure, and I'm happy to talk about that in question time, or supplementation that avoids vitamin D deficiency. And I just thought I'd flag why we do need to have a look at our policy settings. These are data from the Australian health study, and they're over a decade old now. There is new data, it's just not released yet, so I haven't seen it. But it looks at the prevalence of vitamin D deficiency in summer and winter across Australia. And you can see that in summer, even at summertime when we've got a lot of UVB around, 20% or so of people in southern states are vitamin D deficient. But what's much more concerning is that in winter, up to 50% of people in southern states are deficient. And given what I've shown you about the importance for infectious disease, which occurs more commonly in winter, that is actually a problem. So we used to think, oh, well, a little bit of a dip in winter is not a major drama for bone health, provided that your vitamin D is okay for most of the year. But now that we think that vitamin D plays a really important role in infectious disease, that sort of policy setting to say, well, we'll just let people become a bit deficient in winter almost certainly is not appropriate. So we do need policy settings to have a look at what we're recommending should happen during winter. And also taking a bit of a look at what's going on in summer. So haven't included any slides on sun exposure, but we have just recently released a new position statement on sun exposure that takes into account this need to consider vitamin D sufficiency throughout the year. I would like to finish by acknowledging the funding for this study. It came from 2 consecutive National Health and Medical Research Council grants. And in fact, before we launched Big D Health, as we call it, we did Pilot D Health, which was also NHMRC funded. So it was actually 3 NHMRC grants. Investigator team listed there, project management, and then many other study staff who made those 100,000 phone calls and looked after our data. And I would particularly like to acknowledge Mary Waterhouse, who has been the powerhouse analyst supervising all our analyses and leading some of our publications. Thank you very much. I will leave it there and stop share and answer any questions.
Thanks, Rachel. That's fascinating stuff. And so we're very happy to answer questions. So if you've got a question, please type it in the Q&A box. But maybe I'll kick off. And my question is, if you hadn't had access to linked data, what impact would that have had on the study and the study outcomes?
Well, I honestly don't think we would have done the study, because in any study like this, in any cohort study, basically, missing data is a potential source of bias. And it's really interesting, actually, that by using linked data, we didn't have to rely on self-report, which means we didn't have potentially biased missing data. And if you compare the results of our trial with a similar trial that happened in the United States, they didn't see evidence of benefit for things like major cardiovascular events. But when you have a look at how they captured it, they relied on self-report, and they did then verify, if people told them that they had had an event, they went and verified that, but they didn't capture events in people who'd withdrawn from the study. And if their study is anything like ours, they chose not to report it, actually, but if their study is anything like ours, they had fewer people in the placebo group completing questionnaires, and that would have meant that they actually under-captured events in the placebo group, which would have masked any benefit. So actually, the complete capture of events is incredibly important to minimise bias. And had we not been able to capture the linked data, I don't think we would have done the study.
That's good news for us.
Absolutely. Yeah, you need to stay in the job.
Yes, we'll maintain the importance of linked data. Another question from me was actually about hypothyroidism. And did you look at parahypothyroidism, or would there have been a way to look at it?
Yeah, well, only through procedures in hospital data. And it just doesn't occur commonly enough. So one of the things that we always did before we began an analysis was consider how frequently the events had occurred and whether or not there was even remotely close to sufficient power to take a look at it. We felt strongly that analysing things where we were going to be very badly underpowered was not an appropriate thing to do. So before we began any analysis, we had a look at how many events we actually had in the data set.
Sure. Interesting about that. What else? People, please, Rachel's really happy to answer questions. So get your fingers moving and type a few questions in.
I can answer
Um,
questions about sun exposure too, if anyone's got them. That's not
yeah.
something that I spend a lot of time on.
My next question was how did you actually predict vitamin D levels?
Mm.
What methodology did you use to do that?
Yeah, so we used the blood samples that we collected from the placebo participants through the trial. And we had samples from our pilot cohort actually. And we basically just did standard prediction modeling, classifying people. We actually did it a couple of different ways, predicting people's actual concentration and then predicting their it as a binary outcome, just using standard statistical prediction techniques. We actually use boosted regression trees to do it, which is good because it accounts for missing data. So things that went into the prediction model were things like age, sex, BMI, smoking, physical activity, health events, etc. So yeah, we just
And
did
not geographic location?
yes, we did use,
Yeah.
well, we didn't use geographic location. We used UV at people's location where they lived. So, which is basically similar. Yeah.
Yeah. Okay. We have a question. I see that 60,000 international units per month is a much higher dose than standard one-a-day supplementation. Is there a reason for that much higher dose?
It's actually not that much higher. It's equivalent dose to 2,000 international units per day. And you'll see that that's actually a pretty common dose for people to use. The recommendation for the dose that would be considered that is the tolerable upper limit is 4,000 international units a day, although 10,000 international units a day is considered safe. So there will be many people out there who are taking 2,000 IU tablets a day. So this was consistent with that dosage, but delivered monthly. And that's because the pharmacokinetic studies showed that whether or not it's taken daily, monthly, or weekly, you end up with the same 25 hydroxy D concentration. Having said that, since we started the study, there has been some evidence emerge. It's not reliable, but there's people making a lot of noise about it, that monthly dosing is not as effective as daily dosing. Interesting though that the trial that I just mentioned in the United States did use daily dosing and their compliance was much worse, which could be the other reason, in addition to potentially biased outcome capture, could be the other reason that they didn't see some effects. But they saw a potential effect for cancer mortality that we didn't see. So it might be that monthly dosing has benefits for some things and not for others. At this point in time, I probably wouldn't. Like in a trial setting, it was really great because we could get great compliance. But just in light of some of the evidence that's emerging, I would probably aim for daily or weekly dosing rather than monthly.
And I know some people, is injectable vitamin D also an option? But some people use
Yeah,
clinically
look,
or
yeah, it is. And unless someone's really severely vitamin D deficient and needs to have their vitamin D returned to normal fast, we wouldn't be recommending that. Again, because of this, there's actually some evidence that taking big bolus doses causes an increase in falls in elderly people. So yeah, we wouldn't recommend that.
Next question. What's the current recommendation at the population level in regard to sun exposure in both summer and winter for optimum vitamin D exposure? What needs to be taken into account at an individual level?
Well, I can help you with that. Although
Good.
right now I can only help you with it if you take part in my research study. So if you Google sun balance, QIMR sun balance study, you'll be asked to complete a survey, but then after that, you will get your own sun exposure advice about how you balance the harms and benefits of sun exposure, taking into account the time needed for vitamin D. You'll be able to access that advice, and then we'll ask you to complete a follow-up to tell us what you think about that advice and whether or not you understand it and are able to implement it. But basically, what we've done for the first time ever is recognise that the balance is not the same for everybody in the community. So for people with very dark skin, they don't really get skin cancer caused by sun exposure, and that they are at higher risk of vitamin D deficiency and need longer time outdoors. So we're recommending no routine sunscreen use, spend time outdoors. For people who are at very high risk of skin cancer, we're actually recommending don't try and make vitamin D naturally. So these are people with past history or who are very fair skinned. Actually, sun avoidance is the appropriate thing to do, and to take a vitamin D supplement. About 1,000 IU a day is enough for most people. And then, although you can take 2,000, we've shown that it might be beneficial. And then for people in that sort of intermediate group, actually it's not unreasonable to aim to spend a short, and I would emphasize a short amount of time outdoors during the middle of the day with as much skin exposed as possible. But in southern states in winter, in order to maintain your vitamin D through winter, you do need to be outside for kind of up to an hour in shorts and a t-shirt. And if you're living in Hobart, that's unlikely to happen, which is why so many people down south are deficient in winter. So basically, if you can't follow out the amount of time we recommend, which most people can't in winter, you're going to need to take a supplement. But yeah, you can get that by going Sun Balance, QIMR, and you will get your own personalized printable PDF that you can stick on the fridge.
Excellent. We should look that up. What were some of the reported side effects in the study?
We didn't have any. Well, it depends. So you will have seen that I noted 5,500 or something adverse events. In a trial, an adverse event is that anything that happens to anybody is considered an event you have to report. So, someone who fell down the stairs would be considered an adverse event. Someone who got a rash is also considered an adverse event. So we have to document everything that happens. So even someone who got hit by a car, clearly not anything that we could have done, that's considered an adverse event. So those 5,000 things are adverse events, but in terms of whether or not it's a side effect, that depends on us having said that it was related to the study. And that takes into consideration when it happened in relation to, when you took the tablet, etc. So we did document a whole heap of gastrointestinal upset, rashes, but it happened the same in the placebo group as in the active group. So if it was our tablets, it was not the vitamin D, it was the excipient that the vitamin D is sitting in. And that seems unlikely. It was a tiny little dose of soya and vitamin D, and vitamin E just as a stabilizer. So it was mostly soya oil. So look, possibly, but it was a tiny dose. So yeah, no real side effects. We certainly, the side effects of too much vitamin D, hypercalcemia, and we didn't see any hypercalcemia.
Excellent. Do you think you've had enough time to follow up, capture events like mortality and cancer?
Yeah, we were powered for that with that amount of follow-up. But I guess you're probably asking about, so one of the really important things is that people tend to want to use results from RCTs to say, is something causal or is it not? I don't think we should be doing that, because the lack of an effect does not mean there is no causal relationship. It just means that supplementing people with that type and dose of supplement for that amount of time at that period in a person's life does or does not have benefit. And so the lack of benefit for cancer, for example, does not mean that if we don't know, we haven't analysed cancer in our data set, but the lack of benefit for all-cause mortality, it's possible that if people have been supplemented for a lifetime, it might have had benefit. So that's our issue. Now, we could do more linkages and do sort of post-trial follow-up for mortality. We've chosen not to do that because we no longer know what people are doing, and there could be a whole heap of the placebo group that are now taking a lot of vitamin D, and so we don't know whether or not it's that we would still only be assessing the effect of what we did for that 5 years, and then any change in vitamin D supplementation in the two groups after that could completely mess with what happened then. So I've chosen not to do it.
Next question. Do you have the sample size and data to look at fracture risk, specifically in people taking medications that reduce bone density? Oh, well, you'd need some extra data from the PBS, I guess.
We've got all PBS data.
Right.
Well, I'd be interested to know which medications we should look at, because that's not my field of expertise. So we just looked at fracture risk overall. We haven't looked at fracture risk in subgroups according to medication use. We could do that depending on how many people were taking the medications of interest. It would be underpowered, but we could have a look. So if someone wants to email me with the list of potential medications, we can certainly take a look at that.
There we go. Potential for a collaboration. Um, then we'll leave that one to last. Is there a reason why you chose older adults? Do you predict there'd be a benefit in the younger population too?
Oh, look, plausibly, to some extent, it's pragmatic in that if you need people to have events, so mortality was our primary outcome, we would have had to have a much, much, much bigger sample size if we were intervening on younger adults, because they're less likely to die and less likely to experience cardiovascular events and cancer and all those sorts of things. So it's partly a pragmatic decision, but a pragmatic decision based on evidence that suggests that vitamin D can act quite late in disease processes. So we would expect, even if someone has sort of partway down a disease process, that vitamin D could have a benefit later in the disease process. So we would still expect it to potentially have an effect in older adults.
And a nice final question, I think, is what's your team following up, investigating now and in the future? Well, you've already told us about one study, but maybe there's other things you're up to as well.
Yeah, so look, it's really interesting because everybody writes at the end of every manuscript, we need more data. And journalists are always saying to me, so how are we going to get more data? And my answer is, in terms of trial data, like there are people calling for more trials in people who are vitamin D deficient. And I'm like, well, we can't actually do that because it would be unethical. If we knew people were vitamin D deficient, to supplement them for 5 years, to randomize them to a placebo for 5 years, if we know they're vitamin D deficient, we can't do those sorts of studies. I think we need to live with a little bit of uncertainty now and make policy decisions on the basis of the data that we do have. And so I would be concluding that trying to do more of big trials is not worth doing. Is it worth doing trials specifically to look at things like cancer survival? Quite possibly, and we're contemplating those sorts of studies. But again, it's very hard because there's been so much noise about vitamin D that many people are already taking fairly high doses of supplements, and particularly when they get diagnosed with something like cancer, they put themselves on everything they can that might be a benefit, so they take a vitamin D. So I think we've got to the point where it's going to be very difficult to do any more studies of this, and instead we just have to make decisions about policy and clinical decisions on the basis of what we already have. We've just working now partly on this, how do we balance the harms and benefits of sun exposure and bring supplementation into that story. We're doing the analysis at the moment on a study looking at whether or not daily sunscreen application actually causes vitamin D deficiency. Current guidelines are that we should all be putting sunscreen on except if you've got really dark skin, but apart from that, we should be putting sunscreen on every day when the UV index is forecast to get to 3 or greater, which is most of the year in most states. We don't know if that is going to cause vitamin D deficiency. So we've done an RCT on that to have a look at that. So yeah, I'm kind of focusing more on how we get this balance right at the moment. But in terms of what more we can do with vitamin D, there's lots of Mendelian randomization studies happening, and I think we'll get better data on that, which will tell us a bit more about causality. But it's still not going to tell us how much we need. So I think we're just going to have to live with some uncertainty now.
Well, thank you so much. That was fascinating talk about a subject that actually affects all of us. We're all interested in how much sun and how little sun and when to put our sun cream on and what the long-term effects might be. So thank you once again, Rachel. That was marvelous. And to remind everybody that this presentation has been videoed, so we will put the video up on our YouTube channel as soon as we can. And also to let you know that the next webinar we've got coming up is on the 2nd of July, and it's going to be all about endometriosis. So another interesting topic for you to pop in your diaries. Thank you so much, Rachel.
Thanks everyone for coming along.